Assalamu alaikum. Good morning. In a series of lectures on diabetes mellitus, this is our fifth lecture, and this is primarily for complications, chronic complications of long-standing diabetes mellitus. In previous lecture, we covered acute complication. Now, acute complications mostly are in the form of either hyperglycemia or hypoglycemia or diabetic ketoacidosis or honk, and sometimes some of the acute complications may take on the form of patient may present with diabetic retinopathy. In the long-standing diabetic retinopathy may be just a dimness of vision, but sometimes acute complication in the form of retinal detachment or in the form of a vitreal hemorrhage can present as an acute emergency primarily to the ophthalmology department. Sometimes patients with chronic long-standing diabetes with kidney complication or chronic renal failure can present with acute complication in the form of acute and chronic renal failure as well. And similarly, acute catastrophic complication like stroke or myocardial infarction can also be considered as some acute complication. But now, today we'll be talking of the chronic complications. And if you talk of the complication of diabetes and the cost, how much they cost, it has to be borne by the society or by the healthcare services and by the patient itself. So if we start your patient's treatment in the very beginning of the diabetes and we control it well, initial therapy cost may be just this much. But when you talk of if they start developing complication, acute complication, like we mentioned, diabetic ketoacidosis or say hypoglycemia, the complications may go on to probably the magnitude, right? But it is a major cost of diabetic care is because of the long-standing complication. And the initial therapy cost, if it is around $8 billion per year for the caring of diabetic patient, the long-standing complication, it almost doubles or triples from the initial cost. If you talk of long-term complication due to disease, the progression and the comorbid conditions, definitely they are the reason for increased healthcare burden and cost. Now, this is just to show or highlight that you may have, to begin with, a very nice flourishing green tree, and in the end, after long-standing diabetes and long-standing complication, with all its vascular supply gone, with all of that, it is left with something like this. Again, when you talk of chronic complications, if we start from the neurological complication, almost 2 to 4-fold increase in cardiovascular mortality and stroke because of the diabetes. The cardiovascular disease, again, in the form of myocardial infarction or angina, ischemic heart disease is quite alarming. Patients do develop neuropathies and long-standing cause of non-traumatic amputation, particularly of the lower limb, because of this neuropathy and because of the peripheral vascular disease is almost quite high. Diabetic nephropathy would lead on to end-stage renal failure, and as already mentioned, that diabetic retinopathy is possibly the leading cause of blindness all over the world. Again, the various long-term diabetic complications can be put forward as 40% of the patient would develop diabetic neuropathy, almost 50% would develop diabetic retinopathy, 35% would develop diabetic nephropathy, and 43% would develop cardiovascular disease in the form of myocardial infarction, angina, or ischemic heart disease, and may be manifested as stroke as well. It is customary to describe the long-term diabetic complication in the form of a macrovascular complications and then the microvascular complications. The macrovascular complications primarily are in the form of ischemic heart disease or manifesting as angina or myocardial infarction, cerebral vascular disease presenting as ischemic stroke or a hemorrhagic stroke or maybe as it is a TIA or transient ischemic attack, and peripheral vascular disease, which would be manifested as intermittent claudication or maybe dry gangrene, and then this, when combined with it, may be responsible for poor wound healing and formation of gangrene, infection, and maybe leading to amputation. The macrovascular complication, as I said, can take on the form of coronary heart disease or cerebrovascular accident or peripheral vascular disease, and they account for almost 80% of the long-term complication or macrovascular complication. The cardiovascular disease or the cardiovascular complication of diabetes mellitus can be diabetes is associated with markedly increased cardiovascular not only morbidity but mortality at all stages of its occurrence of diabetes. So starting from these cardiovascular disease complication can occur or present not only in patients with full-blown diabetes mellitus, but even those who just have impaired glucose tolerance or impaired fasting glucose, or even prior to that. As we said, many a time diabetes is diagnosed for the first time when they have a myocardial infarction. So no stage of diabetes or no say level of diabetes is immune to have cardiovascular disease complication. They can happen in any diabetic at any length of diabetes or any duration of diabetes. They can occur. Atherosclerosis is the root cause of macrovascular complications, and it is, as we said, 80% of the diabetic mortality is because of this atherosclerotic complication of diabetes. 75% of those usually die of coronary atherosclerosis and ischemia and angina or infarction. 25% would develop either a cerebral atherosclerosis, cerebrovascular atherosclerosis leading for stroke, and similarly same number would be developing peripheral vascular disease. 75% of the hospitalization of patients with diabetes are because of complications, because of chronic complications. And more than 50% of the patients with the newly diagnosed diabetes already have had cardiovascular, coronary heart disease or cardiovascular disease. This is to highlight that what is the difference in a microvascular and macrovascular pathogenesis. When you consider microvascular, you mainly consider the capillaries and very, very small vessels. Now, capillaries are just a single lining of endothelial cells. This is its nucleus, and this is all surrounded by the cells. And inside this is the basement membrane, and then inside this are the circulating blood, right? So in microvascular disease, there is endothelial thickening, and this endothelial thickening with loss of pericyte would lead on to this basement membrane thickening, would make these vessels more leaky, more permeable, and thus they would start taking protein. And then, of course, the abnormal deposition of this protein and basement membrane would also make it less able to blood supply to that distal most part of the tissues. Whereas in macrovascular, it is the blood vessels or the arteries which would lead on to formation of atheroma. Now, this is the atheroma where the fat or lipid gets deposited in the subendothelial portions, and this is this atheroma which narrows the lumen. Whenever this atheroma gets, say, fissured or ruptured as a result of long-standing hypertension or as a result of a change in character of the tissues, there is invitation for the platelets and clotting factors to start, say, assembling over that point, and then this initiates a process of clotting in order to repair this, and this would lead on to further heaping up of this atheroma, and this would narrow the lumen, and this is narrowing this lumen. When it is a fixed lumen, it would cause ischemic heart in the form of claudication or angina or maybe pain at rest. But when it is totally occluded, this then would lead on to, depending upon which vessel it is. If it is vessel to the heart, it may cause acute myocardial infarction. If it is vessel to the brain, it will cause maybe stroke or ischemia. This is just to highlight that what happens. And now this is the whole lumen of a medium-sized blood vessels. This is the fat deposit inside it, and this is was covered by this fibrous cap. But some fissuring occurred over here, and then there was entry of blood into it, into the this atheromatous plaque, which say narrowed the lumen, and over here the inflammatory process leading on to formation of this side. So this was the lipid, this fibrous cap, this got fissured, and then there was a thrombus formed over here. Now this lumen, which was initially free of thrombus and was able to supply blood, now this has totally occluded, and this is total occlusion in the vessel, which is reason for an acute presentation of uh, as a result of stroke or ischemic heart disease. Diabetes is considered as cardiovascular disease risk equivalent. So this NECP or National Cholesterol Education Program classifies diabetes as a coronary heart disease risk equivalent. What does this mean? It means that it carries, the diabetes itself carries a risk of heart disease equal to that someone has already had his disease. We'll explain this by this figure or this say chart. If you have someone has not had a previous MI, no MI, the chances of this person having an MI are around 3.5 say percent. But if someone has a previous MI, the chances of having another MI are almost around 18 to 19%, right? But look at the patient with diabetes. Those who has diabetes, they have and they have not had a previous MI. They have chances of having an MI. Their chances are 20%, and if they previously had an MI, the chances are almost 45% or double. So someone who had not had diabetes would have a chance of having an MI around 19%, and then someone who has had uh, diabetes but no MI also has the same, which means that the having diabetes means that you possibly had one myocardial infarction already. So that is why we call it the diabetes is cardiovascular disease, say equivalent or CHD equivalent. Then it is not the diabetes alone which contributes to the development of these complications. We have been repeatedly saying it is combination of actually it's a metabolic syndrome. It is combination of obesity, hypertension, smoking, dyslipidemia, and all those risk factors. So the patient who have no risk factors, their chances of developing, say, complication like in say non-diabetic and diabetic are almost this much. If they have one risk factor, the chances of of developing the cardiovascular mortality rate increased to this much. If there are two risk factors, the mortality goes to this much, and if there are all three risk factors, and these risk factors include cholesterol, smoking, and blood pressure. Systolic blood pressure more than 120, smoking. So if you have just diabetes, the mortality would be this much. If you have along with that, and look at this, the non-diabetic and diabetic figures, right? The diabetic would have already triple the mortality as compared to their non-diabetic counterparts having the same number of risk factors. Diabetes, as we said, is not alone. It is associated with other risk factors like obesity, hypertension, hyperlipidemia, erectile endothelial dysfunction, and insulin resistance. And this all they join hand together to cause the complications, to cause, right? The factors interact with each other and then lead to premature and extensive atherosclerosis, as we already explained. Now, the atherosclerosis, as we said, is would lead on to ischemic heart disease, would lead on to peripheral vascular disease, would be responsible for cerebrovascular accidents, and would be responsible for development of hypertension as well. There are some peculiar thing about coronary heart disease or cardiovascular heart disease and diabetes. The incidence of coronary heart disease in diabetic is 2 to 3 times higher as compared to the non-diabetics. The coronary heart disease in diabetes affects younger people. So the MI which happens in diabetic is 10 years. If non-diabetic would get an MI at the age of 65, a diabetic would get it at the age of 55. It at most takes on 10 say years earlier. More so, many a time these patients would have silent myocardial ischemia, meaning that because of say diabetic autonomic neuropathy, they would not perceive the pain, and they may not complain of angina or chest pain. They may have a silent myocardial infarction. They may end up with maybe a sudden cardiac death, or maybe dyspnea starting on without even having experienced a chest pain, or without having experienced a myocardial infarction. Then the chances of sudden death in patient with diabetes and having myocardial infarction are much more as compared to the non-diabetic. Another thing which is of note is that in diabetic patients, the coronary vessels which are involved, they are more distal and more smaller vessels, less amenable to intervention like stenting or like angioplasty, and these probably would be difficult to manage patients as a result of not being able to do for the epicardial larger coronary vessel involvement. There is something possibly can be done as it if they are diagnosed, and they can undergo coronary interventions and say angioplasty or stenting. But diabetic, because of smaller vessel being involved, they are more at risk of developing more extensive disease and still not very amenable to intervention. Similarly, the mortality of patients with diabetes and those who do not have diabetes, there's a lot of say difference that during acute phase or within first say 24 to 48 hours of onset of myocardial infarction, mortality during that very period in diabetic is much higher as compared to those who are non-diabetics. These patients are diabetic patients are more likely to have heart failure resulting from both ischemic heart disease and what we call as a result of diabetic cardiomyopathy as well. On the long term, the diabetic patient with coronary heart disease do badly or have a bad poor prognosis as compared to their non-diabetic counterparts. Even if we go for interventions that we offer them angioplasty, we offer them coronary artery bypass grafting, the prognosis still is poor in diabetic as compared to non-diabetic patients. And once you have done that with the intervention, the chances of recurrence or re-stenosis and rethrombosis or failure of the cabbage are much higher in diabetics as compared to the non-diabetics. So all in all, having diabetes means that you would have a disease which would start very early on. You would have it maybe silent or may not have any symptoms to begin with. When it happens, it would be difficult to manage. Complications are much higher in diabetics. So this requires a very timely management of diabetes and control of diabetes. The second manifestation of this macrovascular disease is in the form of perivascular disease. And when you have peripheral disease, means that the blood vessels into the periphery, particularly the legs and lower limbs, they are narrowed as a result of atheroma or atheromatous plaque being formation, and this results in decreased blood supply to the tissues. In the long run, these patients would develop symptoms like intermittent claudication, as equivalent to, maybe considered as equivalent to angina, which is an aching pain in the calves, which sets on when patient starts walking or has walked a few, say, 100 steps or so, and then as a result of that, the patient feels pain, and when he rests, there is some restoration of blood supply and he can walk again. So intermittently, there is aching pain in the calves on walking, and improved on rest. This is called intermittent claudication. But once this vessel is occluded completely, so as it happens in patients when the coronary vessel gets occluded and you get a myocardial infarction, an acute occlusion of a branch of an artery or a large artery would result in that area becoming dead and resulting in formation of gangrene. As you can see, this second toe in this patient is black and gangrenous. Now, this peripheral disease, as we said, is one of the leading cause of amputation or non-traumatic amputation all over the world, and they can manifest as this gangrene or may result in amputations. The incidence of perivascular disease in diabetic is almost 2.7 times more in men and 3.4 times more in women. Diabetes, as we said, is the commonest cause of limb amputations. The third manifestation of macrovascular disease is cerebrovascular disease. Now, the cerebrovascular disease can take on both forms. It can present as a hemorrhage, as you can see, a large hyperdense area in the deep-seated brains, and this over in the midbrain region. And it can also present as ischemic stroke or infarct as well. Again, if you compare the normal or non-diabetic individual with diabetic men and diabetic women, the incidence is almost 3.5 to 4 times more, and particularly more in the women. Again, the ischemic stroke, not only the hemorrhagic stroke, the ischemic stroke is almost 3.8 times more in men and 4.1 times more in women. The fourth complication of atherosclerosis or macrovascular complication, of course, hypertension. Hypertension have many other, say, factor responsible for it, which some of them may be because not simply because of atherosclerosis, but there may be under interplay of other renal and non-renal components or endocrine component, and of course there's a hereditary component too. But if you talk of diabetics, the prevalence of hypertension type 2 diabetes is almost 50% more as compared to non-diabetic patients. And when this hypertension is superimposed, the incidence of microvascular and both macrovascular complication of diabetes is markedly increased. So once you have diabetes alone, the complication may be slightly less, but when the hypertension is also added to it, both microvascular and as well as macrovascular complications as a result of diabetes are increased manifold. Now, having covered these four major areas of macrovascular complication in the form of coronary heart disease, stroke, and peripheral disease, we now move on to, and hypertension, we move on to the microvascular complication. Again, once back to the initial diagram we showed. Now these medium and large vessels, they are basically responsible for blood supply to all the organs. But this microvascular component is particularly important in nephrons and in retina and in vasa nervosum of the nerves. So when you have a vascular supply to the larger organs gone as a result of atherosclerotic changes, the manifestations were in the form of a stroke or myocardial infarction or gangrene. But when the small vessel, then this nephron involved may cause nephropathy. Retinal vessel involvement in small capillaries would be responsible for retinopathy, and then the vasa nervosum of the nerves being involved would be responsible for development of dysfunction of the nerves in the form of neuropathy. So nephropathy or retinopathy and neuropathy are major complication resulting from microvascular involvement or endothelial dysfunction happening in the smaller capillaries. And this then is responsible for, in combination with the larger vessel also being involved, or as a result of hyperglycemia and decreased blood supply, then responsible for formation of development of diabetic foot or skin ulcers or gangrene. So these three things can be a combination of both micro and macrovascular complication of diabetes mellitus. Something about diabetic nephropathy is a clinical syndrome primarily characterized by albuminuria. So when someone starts excreting more than 300 milligram per day of urine, albumin in the urine, it is called as albuminuria. And or maybe if you talk of in terms of a GFR, more than 200 microgram per minute, and this should be confirmed at least on 2 occasions, maybe 3 to 6 months apart. So if you document that a diabetic patient has persistent albuminuria on more than 2 occasions, 3 to 6 months apart, and the amount you measured was more than 300 milligram, it would be labeled as diabetic nephropathy. Now, this diabetic nephropathy has a progressive declining course, and this would lead on to decrease in glomerular filtration rate, and this GFR then finally would end up in loss of nephron function and then of course the development of renal failure or end-stage renal failure. When this nephron gets involved, there is say involvement of the renin-angiotensin-aldosterone system, and there is an additional element of development of blood pressure as a result of that. The patient may have an essential hypertension, but this once this nephropathy sets in and this nephron starts getting involved, then there is an addition of hypertension to diabetes as well. Again, we talked about the diagram. There is mesangial expansion, there is a glycosylation of the matrix, the glomerular basement membrane gets thickened, it becomes leaky, it starts leaking proteins. These proteins then are responsible for sclerosis of the glomeruli, and this then develops intraglomerular hypertension, and then of course, as we mentioned, renin-angiotensin activation further leading on to say hypertension. So this intraglomerular hypertension is reduced by the dilatation of the efferent artery and from the ischemic injury, and then increased hyaline narrowing of the vessels supplying this glomeruli. If you go for histopathology, the most common lesion on diabetic nephropathy is diffuse glomerular sclerosis, but this nodular glomerular sclerosis, which was previously named as Kimmelstein-Wilson nodules, that is classical or pathognomic of diabetic nephropathy. Kidneys in these patients are usually larger. In most of the patients with chronic kidney disease, we do have shrinkage of kidneys and kidney size becomes smaller, but in diabetic patients, it remains normal, at sometimes may even hypertrophy. How do this diabetic nephropathy presents? It usually is considered when we have a history of following two things in a diabetic patient. One, he may start complaining of passing of a foamy urine, unexplained proteinuria. That would be another manifestation or presentation of diabetic nephropathy. Those who have diabetic retinopathy are almost 100% likely to have involvement of the kidney vessels as well. So whenever someone has diabetic retinopathy, you must think that he would also have diabetic nephropathy, and urine should be checked for proteinuria, and these patients should have a serial monitoring of their urea and creatinine. Sometime when frank nephropathy has occurred and has led on to frank proteinuria, which results in hypoalbuminemia, then these patients may develop a picture like nephrotic syndrome, and their presentation may be in the form of development of edema or development of fatigue and lethargy along with that. You can also suspect someone to have diabetic nephropathy if there are other components or other complications of diabetes present in the form of maybe peripheral vascular disease, or they have hypertension, or they have coronary artery disease. So if they have those which are maybe macrovascular complication, you do suspect that they would have microvascular complication or involvement of the kidney or diabetic nephropathy also. The diabetic nephropathy, starting from just microalbuminuria and proteinuria to nephrotic syndrome, and finally ends up in end-stage renal disease or chronic renal failure. Its leading cause of diabetes remains the leading cause of end-stage renal disease, and the 40% of the patient on dialysis are diabetic patients. The 5-year mortality rate in patient on dialysis is almost 93%. So every effort should be made to prevent this complication to occur, because it would increase the mortality very enormously. How much or which patient are likely to develop diabetic nephropathy? Type 1 diabetic usually 25 to 45% will diabetic nephropathy at some stage of their disease. But when 80 to 9%, 90% with microalbuminuria will progress to overt nephropathy in 5 to 10 years. Nearly 100% of the patient who has gross proteinuria will progress to end-stage renal disease or renal failure in 7 to 10 years. So if you talk of type 1, 25 to 45% will develop, 80 to 90% with microalbuminuria will develop in 5 to 10 years, and nearly 100% with gross proteinuria will progress to end-stage renal disease in 7 to 10 years. The story is different in type 2 diabetics. In type 2 diabetics, 50% will have microalbuminuria at the time of presentation, probably secondary to hypertension. Whereas type 1 diabetic takes something around 5 to 6 years to develop microalbuminuria and nephropathy. Type 2 diabetes, 50% of them are already having microalbuminuria at the time of diagnosis. 10 to 20% in microalbuminuria would develop to progress to overt nephropathy. All diabetics may not be developing nephropathy altogether. So there are certain say characteristics and certain factors which make it diabetic nephropathy more likely in certain groups, and these groups include sometime it may be age of these patients, when the duration of diabetes is also important, some race and ethnic differences are there, but those with the microalbuminuria, hypertension, poor glycemic control, those who smoke, those who have family history of nephropathy, or they may have some genetic abnormality with ACE genes. These are the individuals who are more at risk of developing diabetic nephropathy. Diabetic nephropathy can then be classified into stages. Stage 1 is when you have a marked glycosuria resulting into say osmotic diuresis, and at this stage the kidney is actually filtering more say blood, and hyperfiltration may lead on to slight increase in glomerular filtration to start with. There is increased renal blood flow to the kidney, and there is then maybe slight early renal hypertrophy as well. But in stage 2, when the glomeruli starts getting involved as a result of deposition of protein in the glomerular basement membrane, the thickening of the glomerular basement membrane. Stage 3 is when they start pouring protein. So the first two stages, when the process of kidney damage has already started, may not be even symptomatic at all, or may not be even manifested in the form of any incipient nephropathy. But it is stage 3 nephropathy or diabetic nephropathy when the albumin starts leaking into the urine, and at this stage, if you measure albumin creatinine ratio, that would be between 0.02 to 0.3, and the albumin excretion may be 20 to 200 microgram per minute on a timed specimen. In stage 4, it is called as overt diabetic nephropathy when the proteinuria exceeds 500 milligram per day, or creatinine clearance at this stage starts declining and it becomes around 70 ml per minute, which normally is 100 to 120 ml per minute. So by this time, almost 50% of the function has already deteriorated. Stage 5 is what we call the end-stage renal disease, where the GFR decreases to less than 15%, and the creatinine now starts rising, and depending upon that what other comorbidity these patients have, they may end up in this. So when the creatinine is more than 6 milligram and creatinine clearance is less than 15 ml per minute, this is called as end-stage renal disease. If you go the timeline, that at this stage someone was diagnosed diabetic. So initially there is an increase in GFR. This is GFR in the stage 1 and up to stage 2. But then if you note down, there's a gradual decline in the GFR, and then you may end up in, right? So it may take something around maybe up to 25 years from no nephropathy at all to end stage renal disease. But majority of our patients are diagnosed somewhere over here, and they already have, say, uh, microalbuminuria or maybe proteinuria. So the time taken from here to here may be a maximum of around 10 years. So it's on an average, once the frank proteinuria starts, then it may be 7 to 10 years to development of end stage renal failure. Why we should screen, how should we screen, what to do when we have screened them, that's important. Why we screen? Because as we said that if you are already diagnosing your patient with nephropathy, once they have passed the stage of any remedy or intervention or treatment, they would end up in chronic renal failure and renal disease requiring dialysis, and it would be a lot of burden on nephrology services to have this large bulk of patients being catered. So prevention and treatment of diabetic nephropathy is the mainstay to avoid the development of end-stage renal disease. This can be done through screening. So if you diagnose proteinuria, microalbuminuria at earlier stage and do something in the form of management, you can probably at least delay the development of end-stage renal disease. So microalbuminuria can be checked on spot early morning urine sample when the albumin creatinine ratio is between 0.03 to 0.3. Anything above 0.3 would be considered as frank proteinuria. You can do, as we mentioned, time collection, and more conventional method has been measuring the 24-hour urinary collection, and if it is between 30 to 300 milligram in 24 hours, this would be called as microalbuminuria. Sometime you may have a small amount of protein or albumin being excreted in the urine in the patients with morbid obesity, sometimes with acute illness, fever, urinary tract infection, pregnancy, high protein diet, and even congestive heart failure. So these may be responsible for transient or a small amount of microalbuminuria. And this, of course, needs to be further confirmed and quantified at least on 2 occasions if you are suspecting it as a result of diabetic complications. So in incipient nephropathy, the diagnosis patient should be screened, maybe type 1 should be put on screening 5 years down the lane. So once 5 years have passed from the diagnosis, at that stage you probably start checking them for routinely for every 6 months to 1 year for microalbuminuria. But in type 2 diabetic, as we said, we usually diagnose them when they have already have had it in a non-diagnosed form, maybe 5-7 years. So these patients should be started screening for microalbuminuria right from the diagnosis. The gross proteinuria or macroalbuminuria would be when there is the albumin to creatinine ratio in the urine is more than 0.3, or the 24-hour urinary collection is more than 300 milligram, and microalbuminuria is present for at least on 2 occasions, and then you have to check it for gross proteinuria. Gross proteinuria, of course, is when you start excreting more than 500 milligram of urine in 24 hours, and nephrotic syndrome would be when you have more than 3 gram of protein being excreted. Nowadays, we usually don't go for biopsy because most of it, diabetic nephropathy, probably can be diagnosed based on proteinuria and renal function estimation. But sometime you might have to go for, there may be some other concomitant renal involvement or nephropathy or glomerular disease, which might require a biopsy to be done. So we start screening for nephropathy in type 1 about 5 years after the diagnosis, and for type 2 from the very beginning. We screen for microalbuminuria. We have to optimize the blood glucose control. If your patient is hypertensive, you usually start them on ACE inhibitors and other antihypertensive medication to halt the progression of nephropathy and proteinuria, right? And if your patient is normotensive, you only go for a good glycemic control. Sometimes reducing protein diet is helpful. We have to maintain their blood pressure below 130 and 85, particularly if they have microalbuminuria, and if there no microalbuminuria, it could be around less than 140/90. If there are other associated risk factors like hypertension, like dyslipidemia, they must be treated. And if you are not do not achieve the target, you definitely have to increase the dose of anti-diabetic medications and might have to think of switching them to insulin. And this monitoring of proteinuria should be carried out every 3 to 6 months very regularly. So we do discuss a case scenario of 55-year-old businessman with 15-year history of type 2 diabetes, and he presented in outpatient. He was complaining of severe paresthesias in soles and calves, which was worse at night. He also complained of fainting or darkness before eyes when he stands up from sitting or getting out of his bed. Pulse was 68, blood pressure 160/90 in sitting position, but took a marked drop in blood pressure on standing, which was 110/70. That was possibly the reason of his say fainting or darkness when he stands up. Both dorsalis pedis and posterior tibial pulses were impalpable. There were marked hypoesthesia and dysesthesia up to the mid calves. Hypoesthesia mean decrease in sensations, or dysesthesia mean an altered sensation that a patient feel like that you touch and he feels it like more of a pain. Both ankle jerk were absent. So what's the diagnosis? He's diabetic. He has features suggestive of both somatic or sensory motor neuropathy. He also features of autonomic neuropathy, and then there is the features suggestive of this postural hypotension, again more of an autonomic neuropathy. So this is all in all a complicated diabetes mellitus with peripheral vascular disease, with sensory motor peripheral as well as autonomic neuropathy. This is just to show the structure of the peripheral nerves and how the sensory endings from skin and soft tissue and blood vessels, they then give signal posteriorly to the posterior horn cells, and from there is a reflex arc, and from the anterior horn cells the motor supply, and then the autonomic being supplied from the autonomic ganglion, which control the viscous say sensations and blood vessels and skeletal muscles. The peripheral nervous system, the motor system dysfunction would result in weakness and atrophy. Sensory dysfunction of the large fiber would be in the form of loss of position sense. Small fiber loss would be in the form of loss of pain, and then of course the anterior horn cells dysfunction or motor loss result in loss of reflexes, and then there may be autonomic symptom in the form of increased flushing, dizziness, erectile dysfunction. These are the various manifestations of diabetic neuropathy. Right? The symptoms may be, as said, we already mentioned, motor symptom in the form of weakness, and they are usually of the lower motor neuron signs. Sensory symptoms can be both positive phenomena in the form of more irritability and paresthesias, or negative phenomena in the form of loss of sensations or anesthesia or hypoalgesia. And this hypoalgesia is usually in the form of distribution of gloves and stocking pattern. Cranial nerve involvement, isolated nerve palsies like third nerve palsy or isolated seventh nerve palsy, or maybe multiple cranial palsies, or even peripheral nerve palsies can result in various nerves being involved independently but in collection. This is called as mononeuritis multiplex, or a single nerve involved, and there are multiple nerve involvement which are not in continuity or not contiguous. The autonomic manifestation in the form of urinary incontinence, portal hypotension, erectile dysfunction, impotence, or diarrhea, and sometimes maybe constipation may be there. So when you are taking history of a diabetic patient, you do ask about these symptoms and do assess all these features in the form of clinical examination. Motor, say, neuropathies would manifest weakness, wasting, fasciculation, deformity, hypotonia, or hyporeflexia. Sensory, as we mentioned, may have variable sensations like hypoesthesia, anesthesia, sometimes spontaneous pins and needles and pain sensations, or restless legs, and the pain may have all these characters as mentioned. Cardiovascular manifestation would be in the form of postal hypotension. GIT manifestation can be in the form of abdominal pain, maybe nocturnal diarrhea, sometimes esophageal atony resulting in, say, esophageal dysfunction in the form of reflux, and maybe in the form of a postprandial heaviness. Genitourinary manifestation as impotence, sometimes urinary retention, and vasomotor in the form of cold feet or loss of sweating or profuse perspiration can all be manifested as an autonomic manifestation or autonomic neuropathies. You have to treat the cause to prevent the complications, and the cause, of course, is the glycemic control. So the mainstay of treatment or prevention of all these complications is good glycemic control. The rest of the thing, treatment is symptomatic treatment through physiotherapy, exercise, surgical. Sometimes you have to release entrapment in the form of someone who developed, say, carpal tunnel syndrome. And then, of course, you can sometimes graft and neuropathic pain relief in the form of vitamins, painkillers, anticonvulsant, antidepressants, sodium channel blockers, antispasmodics in the form of antispastic in the form of baclofen, alpha-2 antagonist, and local application capsicum. So all these independently or in combinations are tried for the management of neuropathic pains. The last component of this our description is diabetic retinopathy. This is a manifestation of microvascular complication of diabetes. So it can have two forms, one in the form of background diabetic retinopathy, and sometimes there is ischemia leading on to increased new vessel formation, or this is called as proliferative diabetic retinopathy. The background retinopathy is, say, abbreviated to remember in mnemonics, where HEX, where V stands for venodilation, A is for aneurysm, H is for hemorrhages, and EX is for exudate. So you can find all these in patient with in their fundus or in their retina on ophthalmoscopy. This is just to make you familiar with that how does a normal fundus looks like. This is the optic disc. The brighter red vessels are the veins, and the lighter vessels are the arteries. And look at how they erupt from uh, the retina, and then they go into the nasal side on the temporal side. This is what we call as a fovea, right? So this is again say labeling of this, right? These are the veins. This was the larger halo is the optic disc. This is optic cup, and the lighter vessel is artery, and this is fovea. This is more say detailed view of this. Again, you can look at the caliber of the vein, the ratio of the caliber of the vein to the artery, and look at this silver lining over this blood vessel, which usually happens as a result of hypertension. This is an example of say diabetic retinopathy of background type. What you notice is there are hemorrhages, there are this small lacy type of vessels are new vessel formation, and then there are few exudates. Now these spots are exudates. This is another example of diabetic say retinopathy, where there is a lot of new vessel formation. The problem with this new vessel is that these vessels can leak into the retina, leading on to vitreous hemorrhage. They can lead on to retinal detachment, and these two can be reason for acute sudden loss of vision. So, in summary, the comprehensive diabetic care would involve this to have set goals and targets for your diabetic patients. So, this is what we call an ABCD of diabetes, where you have to maintain an HbA1c of less than 7%, a blood pressure of less than 140/90 in normal individuals, and if they have microalbuminuria, this should be further lowered to less than 130/80. C stands for cholesterol, where primarily your LDL cholesterol has to be less than 100 milligram per deciliters. Diet, D is for diet, where it should be low carbohydrate, low fat, and high protein diet. And if there are no contraindication and there are not much of a say neuropathies and peripheral vascular disease, these patients should exercise, and they should have at least 30 minutes of daily walk. Now, if you do that and then you combine it with the therapeutic agents in the form of oral hypoglycemic agents and insulin for achieving a good glycemic control of less than 7, you have to treat their blood pressure through antihypertensive drugs. You have to prescribe for cholesterol in the form of statins, and they may also be advised aspirin as an antiplatelet. This brings us to the end of our 5 lectures on diabetes. We have covered it in much more details, and thank you very much for bearing with me and having this extended section.